So, good morning, good evening, everyone. How are you? My name is Joki Washira, and I guess now we can start the session. I welcome you all to the 11th session of this COGS tele-mentoring series on strengthening obstetric and gynecological care for maternity teams. Today's topic is on puerperal, sorry, that name is just mixing me up, sepsis and perioperative care. We at Equalize Health have partnered with COGS to bring this online series. We have implemented several tele-mentoring programs with health professionals, just like yourself, in India and in Africa. So just to begin today, we would like to start with some housekeeping announcements. Keep yourself muted unless you're talking. Keep your videos on if possible, and respond to questions without any hesitations. You can also post your questions on the chat box. And at this moment, I want to ask Dr. Kigondu to introduce the speaker for today. Thank you.
Thank you very much. Thank you very much, Njoki. Thank you very much. Today we have the pleasure of having Dr. Douglas Mwaniki. Dr. Douglas Mwaniki is an obstetrician gynecologist at the Nazareth Hospital. Over and above that, Douglas has studied extensively physiology. I'm sure for most of us, physiology is one of the harder subjects. And today we are pleased that he will take us through puerperal sepsis and post-operative infection, a very important topic and a cause of a lot of morbidity and mortality. And with that, I think I would ask Douglas to share his screen and continue with the topic. Is Mwaniki able to?
Good evening, everyone.
Good evening, Douglas.
Good evening.
Are you able to see my screen?
Put on slideshow.
Can be able to see my screen?
Yes, we can.
Put on slideshow. Yes, it's visible.
Yeah. Thank you.
Njoki Oshira, I hope I'm clear.
Yes, yeah, we can hear you, Dr. Mwaniki.
Thank you so much for the opportunity to discuss this topic with the team that is concerned with the caring for women, whom we are all very passionate about. Today we are going to discuss puerperal sepsis and perioperative care. We'll go simply through the background and significance of puerperal sepsis. We look at the risk factors for people, try to alert us on some red flags on puerperal sepsis and what will happen so that we can be able to recognize early and manage in time. And then we'll also discuss the management for puerperal sepsis, where we look at the history, the examination, and the diagnostic workup, and the multidisciplinary management of these patients with puerperal sepsis. And of course, we'll always want to prevent that. So we look at the prevention, antepartum, interpartum, and postpartum prevention. Puerperal sepsis is one of the big five. And the big five, this time not in the good way, but the big five that cause highest mortality and morbidity in our areas and in our setup. So you can see sepsis is coming after hemorrhage, hypertensive disease, and it ties with abortion, unsafe abortion, as leading causes of maternal mortality and morbidity. In addition to the mortality, the morbidity associated with puerperal sepsis is significant in terms of it causes a huge financial burden to the patient, going to the intensive care unit, prolonged hospital stay, and sometimes it leads to even some permanent disability or long-term disability that may even reduce the earning capacity of this parent. If you look at the risk factors, the common risk factors that we find identified include obesity, anemia, suboptimal personal hygiene, rural residents, poor education levels, low socioeconomic status, and 1 to 2 antenatal care visits. That's poorly attending, poor follow-up during the antenatal care, prolonged labor, more than 5 vaginal exams during labor, and CS delivery, prolonged rupture of membrane.
We've lost Dr. Mwaniki.
Yeah, did we lose Douglas? Give him a call. Washira, tell him we've lost him, although we can still see his slide.
Okay.
So as they are trying to get Dr. Mwaniki back, our last session will be on Wednesday on premature rupture of membranes. And after that, at about 8:15, we'll have a small closing ceremony where we may be giving out virtual certificates for the very fantastic attendance that we have had for this series. As we have said, the series are available on the Kenya Obstetrics and Gynaecological Society YouTube page. So feel free to share with your maternity teams so that you can keep repeating these lessons. And we want to have feedback from all of you as to whether these sessions has been useful and what we should be doing in the new year. So on Wednesday, we'll have one on preterm premature rupture of membranes, a very important subject. And we will have a few remarks as closing and
Yes, you're back.
Okay.
Oh, Douglas, yes, thank you. Very welcome back.
Okay. Sorry, I think the internet was misbehaving on my side. At what point did you lose me? Had we discussed the
risk
factors?
The risk factors, yeah.
Thank you. So anemia, suboptimal personal hygiene.
Share the screen. Share the screen. We can't see the screen. Yeah.
Okay. Sorry. Can see my screen now?
It's coming on. Let's give it a, yeah, there now we can see it. Just put it on slideshow. Yeah, thanks.
Okay, sorry for that. Anemia, suboptimal personal hygiene, more than 5 vaginal exams during labor, prolonged rupture of membranes. These are the main causes of the main risk factors for puerperal sepsis in our setup. We have the common organisms that are known are group A streptococcus, especially Escherichia coli. We have Staphylococcus aureus, especially for patients who have been admitted in the hospital for a while. And there are others that are like gram-negative bacteria that produce beta-lactamases have also been isolated in patients with a septic shock. But most of the patients, we don't do culture and sensitivity and microbial studies. So we end up not knowing the exact organisms that cause this, the puerperal sepsis in our setup. This would be assisted by, if we end up doing more cultures, we'll end up getting our own local data of what are the main causative organisms, but it's not very different from group A streptococcus and the list we are seeing here as at now. So the red flags, you see a patient coming back, or by the time you're discharging a parturient mother postpartum, and you see there's pyrexia, there's fever more than 38 degrees, there's tachycardia, there's tachypnea, and some non-specific chest pains, abdominal pains. Some will have renal angle tenderness or uterine tenderness, or they seem just generally dull, anxious and distressed. And when you assess this, it's not due to the postpartum blues or the fatigue of taking care of a newborn. These are the kind of mothers you need to watch out keenly so that they don't transform and you end up having to take care of them when they have severe sepsis. And one key thing I would like to ask ourselves is, how many mothers do I counsel on danger signs in puerperia? Most of us in maternity, after the baby is born, we tend to take care more of the baby, and we think we've finished our work with the mother. During antenatal care, we are very good at giving the mothers the danger signs. But if you ever get a mother in puerperium and ask her, what were you taught are the danger signs during puerperium? None of them will tell you this. Although they're usually in the blue book, in the ANC book, they cannot tell you there is pyrexia or abdominal pain or foul smelling lochia. Those are the things that can cause danger signs. So I think that's one aspect we may need to keep or to work on, so that we counsel them more on danger signs as on both the mother and the baby. When this patient comes to you, you of course have to take a very detailed history. You want your history to show you the antepartum history, the intrapartum history, and the postpartum period. Because as you've seen on the risk factors and the causative, most of these organisms and the effects would have started before even the delivery, when they were during the pregnancy, and it would be nice to look at them. So in your history, you want to know mode of delivery, you want to know if there was premature rupture of membranes, prolonged rupture of membranes, you want to know how the prenatal care was. Did she attend clinic infections? Was there UTI? Was there respiratory? And then had they been assessed for group A streptococcus colonization? We know about 30% of our women have group A Streptococcus agalactiae as a microbial infestation in their normal vagina. So did they have this assessed, and were they given prophylaxis for that? And then of course you assess the patient's symptoms. The common symptoms are those related to fever. You'll get hotness of body, rigors. Some may come with diarrhea and vomiting, because any system may be invoked. You can also have the breasts, it can be engorged, redness, can even spread and become septic. You can never to the level of getting a breast abscess. You can have a rash, generalized maculopapular rash. Sometimes it's just the pain, or if it's a cesarean wound or an episiotomy wound, you may see it's infected, will be discharged. The lochia may become offensive and with changes. If it's too smelly, suggestive of anaerobic infection, or serosanguinous, suggestive of streptococcal infection. They could be having an upper respiratory tract infection with productive cough and difficulty in breathing. There are also urinary symptoms. Delay in uterine involution, that one you may pick as you are examining the patient. And general lethargy and generalized malaise. So when you find this patient, how do you manage this patient? One, you want to you don't know how severe the sepsis is. The sepsis can be mild, as just breast engorgement or just mastitis does not reach, or it can be severe that the patient comes to you in a coma, or the patient comes to you unconscious. So what do? You have to do the primary survey. You have to do you have to check the airway, you have to check the cardiovascular system, you have to check the breathing, you have to do full evaluation after stabilizing the patient, and then you go to head to toe examination in your secondary survey. As you're doing your head to toe examination, be keen, because every part can be the portal of infection. The infection could have come from the breast, so you check for mastitis. It could have come from the upper airway, check for the respiratory tract infections. It could have come from the vaginal orifice, so you check for endometriosis effects, and also check for wound infections, and look for also septic thrombophlebitis. And then once you see this patient, the next thing you want to do is to discuss this patient and put this patient, record the vitals and monitoring on something we call a MEOS chart. MEOS chart means maternal early warning signs. Those are the things that you want to look at in the mother. You want to check the respiratory rate. You want to check the heart rate. You want to check the fever level. And with this, you can grade the patient and know, can this patient be managed in the general ward? Does this patient need management in a higher dependency unit? Or does this patient need management in the ICU, in the intensive care unit? Then you can classify as such. And then this will also help you know, do I need to intubate this patient? Do I need an anesthetist on board? Do I need a pediatrician on board? And the microbiologist who may come and help with the culture and sensitivity. So the MEOS chart will have this. It will have the red triggers and yellow triggers. You'll be checking at the temperature range, the blood pressure, the heart rate, the respiratory rate, the oxygen saturation, and some also include the pain score and the neurological response. And with this, you'll need to know, who are you going to call? Which team do you need for management of this patient? Because time is of essence when managing this patient, and correctly classifying a patient to where they belong and managing them in the right setup with the right team is as urgent as initiating the initial antibiotics. So when they come, after you've evaluated them, the next thing you want to do is to do the investigation. You want to see the baseline investigations, and also the other investigations will be guided by symptomatology. So you'll do full hemogram to see if there's leukocytosis, and then you'll do the CRP, C-reactive protein, to see as a marker of acute inflammation and see how much the infection has spread in blood. Then you'll do your urea, electrolytes, and creatinines, and then you will do culture and sensitivity. If there is a wound that is discharging pus, you take swabs from that wound. If the vaginal discharge is offensive, you take also discharge from that. You take a swab from that. You can also take an endocervical swab, and then you take blood and urine. And then these ones will help you in choosing the appropriate antibiotic that you're using. You'll check the lactate levels. Lactate levels above 4 millimoles per liter, you suspect sepsis. And the more the lactate levels increase, the higher the level of care that the patient needs. You'll also do coagulation studies so that you also take care of the patient in terms of venous thromboembolism and surgically preparation. And then in case you need to approach the sepsis surgically. And then imaging will help us see things like abscesses. We'll even see retained placenta. You may even see an infected clot in the pelvis, maybe during CS, if there's an infection pocket. Sometimes it could even be a foreign body that was retained there and is causing the sepsis. We'll see them through imaging. Then sometimes you may need to do a CT scan or MRI, but those ones to mainly rule maybe appendicitis and pelvic thrombosis, and when need be. The baseline and your investigations should mainly be guided by the symptomatology of the patient. So in management, when the patient recovers well and everything goes well with the patient, we are all heroes. So don't struggle alone. That's why there are different specialties whom you can work with. Rope in the obs-gynae in time, rope in the pediatrician on time to inspect the cord of the baby, to inspect the baby, to see if the baby has also been infected. Bring in a microbiologist who will help with the culture sensitivity, and we will even give you advice on microbial studies that have been done and help you with empiric antibiotics, the choice of empiric antibiotics that you may want to use for that particular case. Bring in intensivists for patients, even before they need the ICU care, they can be assessed so that even by the time if they get worse and they need ICU care, the intensivist is already on board. The pharmacists will also advise on medication and everything. The nursing team, they are very key, very, very key, especially with the monitoring of the patient. And they're the ones who will actually pick some of these red flags and alert us. And the clinicians who are on board, because they are the ones who have primary contact with the patient. So everyone is important in this team because everyone contributes in one part or another to make sure the patient is safe. The next thing you want to do is to deal with the infection foci. Where is this infection coming from? What is the site? Is it coming from the breast? Deal with that. Is it coming from the uterus? Deal with it. Is it a clot that is been formed in the pelvis that is infected? Drain it. Is it a retained gauze or a foreign body that has been retained inside that is causing this infection? Deal with that. So deal with the specific foci of infection. And then after that, the antibiotics, you start with empiric antibiotics because you can't wait for the microscopic culture results to be out and the sensitivity pattern to be out. The empiric antibiotics we use will be guided by the previous patients whom we've done microscopic culture and sensitivity on. What did they have? What are the common antimicrobial pattern in our environment, in our locality, in your hospital? That's why if the microbiologist is on board, on the lab person, they will tell you, no, for most of our patients here, we see them, they have Staph aureus, we see them, they have Escherichia coli. And yet when you examine the sensitivity pattern, we find they respond better on these antibiotics, which may help you in picking the empiric. Broad spectrum is the next thing you want to do is to take the immunoglobulins. Is there any role for them? Is there any role? Have you heard of any role of IV immunoglobulins in sepsis management so far?
Can put the answers in the chat box.
Yeah, the 30 seconds, they can put the answer in the chat box. Yeah, Mwaniki, no one has ever heard of those things. Explain.
Yeah, IV immunoglobulins are usually to taper down the immune response. Sometimes the immune response can be exaggerated, and then you can have an overload of cytokines. The cytokines, when there is an overload, they can lead to pulmonary edema, and they can even cause damage and lead to pulmonary failure. It's one of the proposed mechanism through which COVID is bringing in respiratory failure. So to taper down the immune response, sometimes when the sepsis is severe, especially from streptococcal organisms, you can be allowed to give IV immunoglobulins, which will taper down the immune reaction to avoid that cytokine storm that can bring problems to the patient. But mainly this will be done for most of the time, the patients who are severely infected, the patients who are probably in ICU care. So which antibiotics do we choose? Which ones do we go for? As you've seen, the microbial studies will help us guide which ones. But before we get the microbial pattern of our place, we tend to use the broad antibiotics that are locally available. So these are some of the antibiotics that you'll get in our setup. We have a co-amoxiclav that's mainly containing a penicillin and clavulanic acid. What you need to know about this does not cover methicillin-resistant Staphylococcus aureus, nor does it cover some of the gram-negative bacterolactam producing bacteria. And then there is metronidazole, which helps with coverage of anaerobes. Then there is clindamycin, which will cover generally most of the streptococci and staphylococci. And then sometimes it's not renally excreted nor nephrotoxic. And then we have the piperacillin, tazobactam, and carbapenems, which are a bit higher. And we have gentamicin. So most of the times in our hospitals, we tend to use one of these as the empiric antibiotic we use. And there's also another common antibiotic which we use, which is not in this table. Which one is it? Ceftriaxone, yeah? So from this spectrum, in OBSGYN, this is a spectrum we can use. When you look at our antibiotic spectrum for OBSGYN, most of the infections that we have include these: anaerobes, Clostridia, bacteroids, streptococci, and then we have methicillin-resistant Staph aureus, or Staph aureus which is sensitive to flucloxacillin. And then we have group A and group B, streptococcus. And then we have the gram-negatives, the coliforms and pseudomonas. So you can see the different antibiotics and what they cover and what they don't cover. So depending on what antibiotic you suspect, what bacteria you're suspecting might be causing the problem in the patient, you might have to choose from one of these antibiotics. And this chart will be very nice for you to look at. So you can see what coamoxiclav is covering and what it's not covering. You can see what cefuroxime is covering and what it's not covering, which makes it a bit easier for you to be able to pick an empiric antibiotic. Then who goes to ICU? Who goes to ICU? The patient's hemodynamic status will guide you on who goes to the ICU or not. If you see a patient has hypotension or have raised serum lactate despite fluid resuscitation, this may need inotropic support with dobutamine and with dobutamine mainly in the ICU, and sometimes they'll use some adrenaline to help in resuscitation and maintaining this. And then for respiratory system, if you see this pulmonary edema, someone needs airway protection or mechanical ventilation, they may need ICU care. By the time the sepsis has become severe enough to cause renal impairment, that is most of the time it's pre-renal failure due to excessive venodilatation due to sepsis caused by the gram-negative bacteria. That level of sepsis is usually too severe, and this patient usually needs ICU care. And then with decreased conscious levels and multi-organ failure, you could be heading to septic shock. So there is this group that has been working on improving survival for patients with sepsis, and they have crafted a management strategy called Surviving Sepsis Resuscitation Bundle. So with this, they give you the guidelines and the timelines on how to first to act on sepsis. But the key thing is act fast, hit hard, then de-escalate. So you act fast, then you hit hard with the antibiotics you know that will respond, then you de-escalate once you have stabilized the patient and now you've gotten your microscopic culture picture, and then now you can de-escalate the strength of the antibiotics you're using. And this one, you don't work alone. In the hitting hard is also bringing in the whole team to hit this sepsis as hard as possible. So for preventing this, the risk factors will be a guide. So prepartum, you've taken, the patient has gone into antenatal clinic. During antenatal clinic, sort out the malnutrition, sort out the anemia, prevent those infections, treat the antepartum infections fully, screen for group A streptococcus, give prophylaxis, and then evaluate for, during labor, also evaluate for things like cephalopelvic disproportion, CPD, so that you avoid prolonged labor, and then avoid repeated examinations. Intrapartum, maintain sterility and cleanliness. All through, sterility and cleanliness, very, very important. The vaginal exams you're going to do, make sure it's sterile. The room, make sure the room is clean. The equipment, everything you use, even the operative room, make sure it's very, very clean. Cleanliness is the best way. It's the most effective way of preventing infections. Because if there's everything is clean and sterility, there is no portal for infection. There is no source of the infection. Postpartum, teach these patients on general hygiene, perineal hygiene, cord care. Antibiotics is a bit controversial. There are people who give antibiotics. There are some centers which they don't give antibiotics. But before you decide on not giving antibiotics, you have to be very sure, you have to have discussed as a team and observed the risk to the patient is very low in your setup. And then the periop care needs to be very thorough. So that way we'll be able to prevent puerperal sepsis. So you look at a lady like Mary, who is going to be the lady we'll discuss today. She's a primary gravida. She presents to the facility where you work for the first time. She has not been attending antenatal clinic. She's just come to your facility. She's probably had rumors somewhere that NHIF or Linda Mama is covering cesarean delivery at your place. So she has come for the first time and asked for cesarean delivery. Let's discuss, how would you take care of Mary from admission to discharge? Anyone feel free?
They can type on the chat, we'll read within 30 seconds to 1 minute. So a lot of people, Dr. Mwaniki, have said you take history and you admit, have an NC profile and profile first, physical exam, and ensure profile is done.
And I've also seen someone put, you have to do a lot of counseling on the pros and cons of different modes of delivery.
Yeah.
You're all very right. Very right. Mary needs to, we need a proper history for Mary, a thorough history for Mary. We need to examine her, and after that, do some investigations. After that, we'll be in a position to know, does she have any indication for cesarean delivery, or doesn't she have an indication for cesarean delivery? So if we find she has an indication for cesarean delivery, we cancel her accordingly. If we find there's no indication, we also cancel her accordingly on both indications. Maternal request is also a soft indication for cesarean delivery. It's also an indication for cesarean delivery. But only when you've canceled and the patient is fully informed and is aware of what is going on. And then you take an informed consent. There's a big difference between informed consent and telling the patient, sign here. And then the patient is just asking me, sign wapi? Because that's basically most of the consents that are taken. That's what we tell the patient. The patient needs to understand what is the reason for the surgery that they are going through. What problem do they have? Why do they need the surgery? How is the surgery going to benefit them? What are the risks of the surgery? And then how are you going to manage the complications? that if they occur, so that a detailed and proper consent form for cesarean delivery should even have a consent for hysterectomy in case of postpartum hemorrhage, should even have a consent explained on when you want this patient to start eating post-delivery, on when you want them to walk, on where you'll put the baby, so that the patient does not wake up, they don't see their baby, and then they start asking, where is my baby? Is my baby dead, or is my baby still alive? So you make sure the consent is detailed. There are a few key things you need to do during the surgery, preoperatively, intraoperatively, and postoperatively to enhance recovery after cesarean section. These ones, they've been modified, and as per the 2021, you find enhancing the recovery after cesarean section has been a key thing that many people have been trying to work for, so that immediately this patient recovers, to be able to take care of the other baby. So because if the mother has delayed recovery, there is delay in initiating breastfeeding to the baby, and the babies ends up getting dehydrated, they end up getting jaundice, sometimes they are fed formula feeding, and they end up developing things like necrotizing and enterocolitis. And then, so to avoid all that, there is advanced repeated continuous effort to improve the recovery after cesarean section. And some of the things that have been noted is adequate patient education is key. And that only occur when you're taking the consent. And then you don't have to fast a patient for a very long time. It's actually been noted about 4 hours of fasting is okay. 4 hours of fasting is very okay. Not the way we fast patients from midday the previous day, and then you're doing the CS the following day lunchtime. This patient has fasted for 24 hours. During this time, you've led to hypoglycemia in the fetus, and the baby is being born with hypoglycemia, the mother is hypoglycemic, even the recovery will be a problem. There is intraoperatively, you also want to prevent hypotension. Hypotension mainly leads to vomiting during the CS, and with that vomiting, you may end up getting respiration syndrome and a very bad experience for the patient. And then you maintain the temperature. Your theater should be warm. For those in Nyeri and Limuru, you try get heaters for the theater so that the patient remains warm. And then use antiemetics intraoperatively and postoperatively to prevent the nausea and vomiting. And then optimal ultratonic administration, oxytocin to be put in at the right time. If you're using carbetocin, also be put in at the right time. And then the pain. Nobody likes feeling pain. So I think as a team, our main role should be ensuring our women don't feel pain, whether physical or emotional. So we use multimodal analgesia, give the patients good pain medication so that they don't have pain, so that they can be able to walk around and even take care of the baby. And then promote breastfeeding and maternal-infant bonding. I know there's a practice in most facilities when the baby is born, it's accommodated in the newborn unit for a while before the mother is ambulant. That practice is not recommended. What is recommended is immediately the baby is delivered, it's attached to the mother, and the mother is encouraged to breastfeed. Postoperatively, don't wait until day 3 for the patients to start feeding. Give them early feeds intake. Within 4 hours, they are allowed to take fluids. After that, they graduate slowly to the other feeds. If they don't feed early and they're already starved, they will not be having enough foods, and the milk letdown will be delayed and bring other problems. Mobilize early, both for quick recovery and also to prevent venous thromboembolism. If you find a patient is the risk factors has risks for venous thromboembolism from the weight, obesity, from the extent of the surgery, and from the prepartum care and conditions, give venous thromboembolism prophylaxis. And the prophylaxis can be in terms of either pressure stockings, ambulation, or even giving blood thinners. And then we continue with pain management, breastfeeding support, and with this, you'll be able to return the bowel function. And in case it's delayed, you can always assist with a stool softener. So for Mary, if we do that, she'll be well informed, and postoperatively, she should be in a good condition to be able to be discharged and go home. And in case she gets sepsis, we should be able to take care of it. Any questions? Any questions?
Thank you. Thank you very, very, very much, Dr. I've seen that time heals broken hearts, not sepsis.
Yes.
There are a few questions in the chat. Maybe I think I can take some of them. When should Mary start oral SIPs post-op?
I can see Linda Odede asking when Mary should start oral SIPs post-operatively.
Yeah.
If you look at the ERAC guidelines, Mary should be allowed to take oral SIPs from around 2 hours post-operative. So, so from 2 to 4 hours post-operatively, she should be able to take oral SIPs.
Yeah, I think traditionally we have been stuck at 6 hours. So this is good information so that when they are told to feed as early as possible, then they can cut. When should removal of catheter and ambulation be done? I'm seeing that next question.
Yeah, Julie, ideally, let's start with the insertion of catheter. The catheter insertion should be done in theater after the patient has been put on anesthesia, so that you minimize the amount of time that this patient has the catheter on. And then immediately after you finish your cesarean delivery, after you finished your surgery, if you find there is no risk for the patient bleeding and the patient doesn't have postpartum hemorrhage, you can remove the catheter still in theater, intraoperative. So you remove it, so the patient is wheeled to the recovery room without a catheter. For ambulation, you encourage the patient to ambulate as soon as as the spinal anesthesia wears off, or as soon as they are fully awake. When they finish, or if it was general anesthesia that was used.
I think Bernard Gidenji has asked what will determine admission criterion for the client suspected to have puerperal sepsis. I think there was a whole slide on that. Was there?
Yes. There was a slide on that, and they should, the admission criteria, technically every patient with puerperal sepsis should be admitted. Where you admit them and where you manage them from will depend on the severity of the sepsis and the management that sepsis will need. If any patient needs IV antibiotics, will need ventilatory support or whichever care they need, most of the time you'll need to put them in. I'm seeing Angelica Ngugi is asking what determines not to give antibiotics after cesarean section. It's a gray area for most areas, because most studies done have showed that you should not be giving antibiotics after you had given the intraoperatively prophylactic dose. So you just give the intraoperative prophylactic dose, and then after the cesarean section, you don't give any other antibiotics. That is what is recommended in most setups, especially for elective cesarean section. For emergency cesarean section, depending on the management before the emergency cesarean section and circumstances surrounding the cesarean section, you usually recommended to give antibiotics. But for our setup, I believe most gynecologists give the antibiotics after cesarean section because these studies were mainly done outside our setup. We don't have local studies in our area that can prove you don't need antibiotics after cesarean section. And so we want to be on the safe side until we get enough data showing that we don't need antibiotics during cesarean delivery. We'll keep giving the antibiotics for our setup. And then,
yeah, so just to add on to that, Dr.
yes.
I think we need to move towards implementing the steps that you had given to prevent infection, to allow our mothers to shower before going to theater, to give, and in our place, for instance, we give the antibiotics during just when theater is starting or just before theater. I think in the era of antibiotic stewardship, we are moving away from that era of just giving antibiotics. Yeah, so of course that would come along with observation and studies. If you note that you're getting more sepsis even after just a single dose, then that can act as a guide. But as we are moving towards antibiotic stewardship, we need to stop using guesswork medicine and apply the policies that of single dose antibiotics, especially for elective cases.
Thank you, Dr. especially for mentioning that when a lady goes into labor, they should go and get a shower first before they go in for delivery. So we should be allowing them to do that, especially if it's elective cesarean delivery in the morning. They should have a shower before they go in. They'll be given the prophylactic antibiotic. And the guidelines currently are you don't give any other antibiotics after that.
There's an interesting question there. What is your take on VVT post CS in regards to sepsis prevention?
Gordon, that's a good question. VVT mainly keeps, it's about removing the blood clots and cleaning the vagina and the vulva after the cesarean delivery. With regards to sepsis prevention, I would quote a colleague, Dr. Karanja Mwaniki from Mombasa, who did a study on this. And he did a study showing where he was looking at when doing VVT, painting the vagina with betadine when you finish. So your last swab that you're doing VVT with, you paint it with betadine versus not using betadine to paint. And he was looking at the sepsis rates for the two sides. And it was shown that even using betadine to just paint and help with the VVT was even improving and reducing the sepsis outcome. So VVT is quite important as you, especially including the betadine painting of the vagina as you clean.
Yeah, and the additional role of VVT is to check for postpartum hemorrhage. You know, as you're doing your VVT, you're seeing how much bleeding is coming. So it's very important to do VVT.
Thank you, Dr. Vivian is observing that showering may be easy for elective CS, but a mother in labor can even pour that water on you. That's that's a good observation. But most of the time when labor is at early stages, the pain is not as intense as such. And usually when a mother gets the labor signs, usually encourage them to take a shower first. Before they get to 7-8 centimeters. Of course, you'll not be telling a lady who is 7-8 centimeters to go take a shower. They might deliver in the bathroom.
A question there. What is the recommended multinodal analgesic combination post-CS by Rose Kamanga?
Rose, thank you for that question. At least nowadays, more people are venturing into pain management. But the key principles in pain management is usually hitting the different pathways of pain. So you'd be using the endorphin pathway. So you use something like a morphine or an opioid. And then you want to work through the prostaglandins pathway. You also want to use an NSAID, which will prevent that. So those are the key things. And then you also want to give paracetamol, which is different from the others. So what you want to avoid is you want to give an opioid, you want to give an NSAID, you want to give paracetamol, you want to use medication that are acting in different sites before you continue. I see Mary Stella is asking, what is the recommended type of anesthesia in CS? Many studies have compared general anesthesia and spinal anesthesia. And unless there is a contraindication for spinal anesthesia has been shown to be superior in multiple things, in fetal outcomes, in recovery post surgery, in blood loss. Yes, even in pain control post the delivery. So spinal anesthesia, regional anesthesia is the one that has been recommended most. I see Pauline Nginyo has asked a question on perioperatively. Kindly review on carbohydrate loading. Carbohydrate loading is the food that contains carbohydrate that will be contributing directly into the glucose levels in blood. So you don't want them to stay away from carbohydrates for too long so that they don't go into hypo. Because if you look at the glycemic pattern in pregnancy, the glucose levels shoot up immediately they eat, but they go down very fast. The levels are not maintained up for a longer time.
There's also a question there from Mary Stella. She says, in case of GA, how long should a mother take before starting oral feeds?
For general anesthesia, most of the time, the lady may take some time before they regain their consciousness. But as soon as the lady is fully awake, more than 2 to 4 hours after the procedure, they are allowed to take the oral sips. and then they graduate as they fully wake up and they are fully conscious. What you don't want is to give a drowsy person oral sip. Even immediately after surgery, and there are ladies who have dryness, they say their mouth, they feel dry and they're feeling too thirsty, they want to drink something. If it's not yet 2 hours, you don't have to stop them, but just tell them to gargle the water. So they take it and they take a sip, gargle and spit it out before the 2 hours, so that their mouth is not too dry and they're not in a discomfort at that time.
Okay. Vivian also wants to know if milk is safe during oral sip.
Milk is safe, but milk tends to bring a lot of nausea, vomiting, especially at around that time. So you may want to defer milk for some time first. And then you see milk being solid liquid, in case the patient aspirates that, it's likely to cause more of the chemical pneumonitis. So you may want just to deal with plain water first.
Yeah, I think there's just one more question there from Rose Kamanga. She's saying, give reference for the 4 hours post-op oral sips, please.
I think you look at the ERAC guidelines, ERAC, enhanced recovery after cesarean section. You have several of them. You have by anesthesia team, by obstetrics team, all of them, and that's what they recommend. They actually recommend 2 hours, not even 4 hours.
Okay.
Yeah, there was a lot of fear a long time ago, but a lot of the fear for a long time ago was because a lot of mothers were under general anesthesia. But in this era of spinal anesthesia, I think feeding is really not a big issue. Very good. I think, Njoki, is there anything else?
No, there is nothing else in the chat.
Very good, very good. I want to thank Dr. Mwaniki for his excellent simplified presentation, and I am sure that our participants have actually caught one or two things. And as I said again, the presentation will be uploaded to the YouTube page of the Kenya Obstetrics and Gynecology Society. We encourage everyone to share with members of your maternity team so that you can learn and relearn. You can use them for CMEs in your place as we continue. Again, I invite you to the last presentation on Wednesday on prom, and we may have a small closing session for this fantastic series. After that, the president of the Kenya Obstetrics and Gynaecological Society will grace the occasion. So we go to the Christmas season with a bang and a lot of knowledge. Thank you very much and have a good day.
Yeah, have a good day, everyone. Evening.
Thank you, everyone.
Night.